So we have an encore presentation from Saibal. He was supposed to speak tomorrow, but he's going to a very cold and ugly place tomorrow morning. So we felt bad for him. So
I'm sorry
we
for
made
giving
a
you
second
another-
talk today. Yeah.
Where? North Korea? Where are you going, Simon?
Thank you for allowing me to just give a talk today. I wish I was there tomorrow because it was rather more important for tomorrow. Anyway, can we go to the questions?
So he's gonna be okay. Do you have your?
How many
Okay.
people are doing left atrial appendage occlusion procedures? So these are the things about in studies comparing left atrial appendage closure versus Coumadin therapy. These are the four things. LAA reduces the risk of ischemic stroke in comparison to Coumadin. There was no difference in disabling strokes in comparison to Coumadin. There was a significant reduction in mortality in comparison to Coumadin. And there was an overall reduction of non-disabling strokes in comparison to Coumadin. This is the data that's good. Okay, that's great that I.
Are you going to go over the answers on it?
Yeah, this is very good that I actually will go through the data. So what I found that this audience believes that, can you go back to the question? Audience believes that the only difference that the left atrial appendage did come to Coumadin was some reduction in non-disabling strokes. So most people believe there's no advance in mortality, most believe there's no difference in disabling strokes, and most believe that it doesn't reduce the ischemic stroke greater than Coumadin. So this is the belief that people have. That's why it's not moved in Canada. So we're going to show you the data for that. Okay, next
These are all
one.
Americans, by the way.
American.
Okay, Ed, what do you think is the right answer? What did you answer?
I actually answered D.
You answered D. What was D?
That was non-disabling stroke.
No, sorry, I didn't answer D. I answered B. I answered no difference.
No difference. Okay, great. Now, another question. What is this one? Patients, the ideal tendon airway closure using the Watchman ambulatory device is patients with persistent AF, valvular AF, patients with non-valvular AF who are a higher risk of stroke but have an absolute contraindication for long-term or short-term anticoagulants. And the third alternative is patients with non-valvular AF who are a high risk of stroke but who have absolute contraindications for short and long-term. So the first one is where you can take short-term Coumadin, but you can't take long-term. And the last one, C, is you cannot take any anticoagulants.
Don't they look the same? B and
I
C.
think,
B and C are the same.
yeah, you read it too.
I like the fact that the audience is split. It's very telling.
I'm reading these and I'm saying.
Yep.
Yeah.
B is where you can take short-term anticoagulants, but you cannot take long-term, right? And C is where you cannot take any anticoagulants at all. So like the true unmet need. Okay, so ideal puncture for a left atrial appendage closure procedure. Low posterior, lower anterior, high posterior, high anterior. Okay, that's great. At least one answer was right. Okay, good. So we are going to show some data for this. That's good. That's right. Let me go ahead. So these are my disclosures again. So the closure strategies for left atrial appendage closure are transcatheter closure, so you have an endovascular approach, or transpericardial occlusion, a lariat procedure, or surgical closure of the left atrial appendage. These are some of the left atrial appendage closure strategies. The top are the endovascular devices, ambular device, Coherix, and the Watchman. The lower one is a surgical approach, AtriClip, you can do during surgery, or a lariat device. A lariat device is a lasso that you put around transpericardial. It's a very clever procedure. And the only device approved in the United States as well as in Canada, I think Canada's got both, or just Watchman, right?
No.
Both. Ambulance also approved?
Yeah.
Okay, for the use of closure with the caveat there's actually reduction of stroke is Watchman. Okay? So this is the procedure. Most people know it's a transseptal procedure. You advance the sheath after
through the fossa, as you said, all of you got correct, posterior and inferior, and then you advance a pigtail catheter into the pulmonary vein, and then you advance the sheath, which is 14 French, and using the pigtail, you advance into the left atrial appendage. So you don't go with a wire. And once the pigtail is inside the left atrial appendage, you advance the sheath, then you take an appropriate size device, which is about 20% larger than the maximal orifice. You bring it to the tip, you retract the sheath, and once you retract the sheath, the device opens up like an umbrella. It anchors with little hooks. You tug at it, you make sure there's no leak, you make sure it's compressed, and if all of these three are fulfilled, then you deploy the device. It's very similar to all other devices that you do every day. What is the unmet need? The question to me was who should and who should not. So the unmet need is there's 15 to 20% of all strokes are AF related. There's over 6 million patients with AFib in the United States. So I can tell you one thing, that the procedures of LAA closure will exceed MitraClips and Watchmans in the next 10 years. Already last year they did 13,000 Watchman procedures in the US. So it's actually going up. I see the Canadians don't believe in stroke prevention, but it's okay. The incidence of AFib continues with the rise of age, okay? You must make sure it's not valvular. What is valvular AFib? Valvular AFib is mitral stenosis or prosthetic valve. Any other valvular disease is not valvular AFib. So if a patient has aortic stenosis, aortic regurg, tricuspid regurg, that is not defined as valvular AFib. Only mitral stenosis with prosthetic valve. So this is what you get. 95% of patients with AFib, when they have this clot, it's in the left atrial appendage. Okay?
Do you believe that?
Yes, I do. Has anybody seen a clot outside the atrial appendage in a non-valvular AFib?
One of the problems is when I look for clot before I close the appendage, I never find it.
Yeah, but that's okay.
Well, but I have an issue with that. So if I do a TE on 100 patients with AFib,
Yes.
I mean, am I going to find clots in
Most
50% of them, 10% without any anticoagulation?
Yeah. No, it's an AFib or sinus rhythm?
No, AFib, no anticoagulation. I see a lot of these patients. I do TEs before to say we can't do the procedure if you have a clot in your LAA, and they don't have a clot.
5%
So then,
of
why are they at risk for stroke?
5% of my patients actually get turned down for LA appendage because they have a clot. Like just do the procedure, 5% I just get. What about John? Do you see the same thing?
I mean, it's a small percentage. I agree, but we just said 90% are
No,
gonna-
95% of the clots, if
clots,
they form.
yes, I know.
Not the opposite
But
way.
the issue is a lot of them are not on any anticoagulation at all for years. Years.
And they're fine.
And they have no clot when I
But the
look.
problem is that you just need a small thrombus to cause a, yeah, right, okay. So anyway, everybody knows that medications work, like warfarin and NOACs work, but the problem of long-term anticoagulation is compliance, bleeding, and failure, okay? And if you compare warfarin versus NOACs, everyone says warfarin is a bad drug. NOACs are very effective. The major advantage of NOACs over warfarin, which is not mentioned, is that NOACs, you get a lot of sponsored lunches and dinners. With warfarin, you don't get that. That's why there's a bigger advertisement. If you look at compliance rate, this is a fact, that by 2-3 years, over 30% are off their medications because they can't take it. And you yourself said that you do Ts on patients who don't take anything. So most of the people, there's at least 30% who are unprotected at any point of time. If you look at this, because of just bleeding, they discontinued the drugs. You can see in the clinical trials, 25% came off their drugs because of bleeding in the clinical trial. Just imagine what happens in real life. And at least 2 to 3% of people have major bleeding on a regular basis because of NOACs. As a result of this, there is need. So what is the clinical evidence? And that's what I want to answer the first question, the clinical evidence. And this is the slide that I'm going to show you. There's only one randomized trial. This is the safety of the procedure. Look at what happened in the first trial. There was about 4.5% bleeding or pericardial effusion or tamponade or device embolization. Look what it is now, less than 1%. So 1% is the complication rate now. In the TVT registry, I don't know what it's like now. Watch, the TV hasn't come out right yet. It's probably
Not the latest.
not the latest, but it's quite low. Pericardial effusion is about 1%, device embolization and periprosthetic stroke is less than 0.05%. So this is the data from the 5-year outcomes of the clinical trials, and this is what I want to show you. The ischemic stroke rate was numerically higher in the Watchman arm compared to Coumadin, but was not statistically significant. But what was the major advantage is that when you looked at warfarin versus ischemic stroke, the dotted line represents the rate of stroke based on your CHA2DS2-VASc score if you were not treated at all. Okay? The solid line represents your risk of stroke based on your CHA2DS2-VASc score if you were treated with Coumadin. And now if you extrapolate all the clinical trials with Watchman, you can see that the risk of stroke in each of the studies would be as though you were on medical therapy. See that? So that's an indirect way of showing that your risk of stroke was similar to what you would get with Coumadin. This is the advantage. So the true advantage is reduction of hemorrhagic strokes, significant. Cardiovascular unexplained death, that was the right answer. That was the reason why the FDA had to approve it. There was actually a clear-cut mortality benefit. You can see a 60% reduction of mortality at 4 years, and of course, all-cause death, and of course, major bleeding and non-procedural related. So the fundamental advantage is, and then there's another point which I don't know in the slide, is disabling strokes. So you had answered that non-disabling strokes were slightly better. This is a proof that the disabling strokes were less in the Watchman group compared to medical arm. And the reason for that is because there was less hemorrhagic strokes, because then the hemorrhagic strokes are much more disabling. And two, the few people who did have ischemic strokes or with the device in were actually smaller. So the fundamental difference between the two therapies is disabling strokes and more long-term mortality benefits. So these are the two things that I tell patients. This is the all-cause mortality difference. Yes.
Sorry to bother you, but
Yes. No.
can you go back 2 slides, please?
Yes. Which one? This one. This is the most important slide to show.
Go back 1 more slide.
Okay.
This slide here.
Yeah.
Is this, these are results of what?
Okay.
This is retrospective controls, actual controls, randomized data.
Okay. Good. So first of all,
Because I would say the math on the Watchman submission for the FDA, which I reviewed,
Yeah.
is about the most complicated statistical
Analysis.
manipulation that I've seen in my entire life.
yeah, that's right.
Right?
It is true. It is very difficult. In fact, the FDA found it very difficult to understand the data, and she's not without the fault. And they were the ones who suggested for us to make this curve, because they said, look, your ischemic stroke rate in the device arm is all over the place. It's ranging somewhere between 1% to 2%. Are you truly protecting people from strokes? John, you were there in the panel, right? You remember. And one of the things that we showed, I don't have that graph, I remember the statistician asking this question, that the few strokes occurred in the first 45 days. But if you follow these patients between 45 days to 5 years, because we had 5-year data, by definition, if it didn't have an anti-ischemic effect, the curve should have spread, right? Because these people are not protected. On the other hand, it was just a parallel line. You got it? Because after 45 days, they're off medications. By definition, they are at the highest risk of stroke, and they should have kept on separating, but it didn't occur, telling you that it did have an anti-ischemic effect. Having said that, I think that there are a few patients who have thrombus on the device, as you saw last circulation paper, and there are a few patients who have a peri-device leak, and those people are at still a risk of stroke.
But those patients, that dotted line is expected. That's an expected rate, right?
The dotted line is the rate of stroke if you were not on any therapy.
But it's not an observed. This is just an assumed. This is an assumed number based on your CHA2DS2-VASc score.
No. The way it came, they went
Some
through
people
two.
had
It's
strokes, what I'm saying. It's you've taken a population, correct, and said, well, your chance of having
no. This was the data that was collected from 2 retrospective analyses in Swedish studies where they actually studied the risk of stroke. This is the gauge analysis. They actually found out this is the number on people. Now we can't do that number anymore because we don't have controlled populations anymore. And this blank line was the studies based on the original studies with Coumadin. When you put all of them together, that's the rate of stroke.
Not NOACs.
Not NOACs. This is not NOACs rate.
That's interesting. Okay.
So going back to the data, this is the mortality benefit, this is of course randomized trial data, where you can see there's clearly a spread of curves occurring as you go, right? There's a mortality benefit, continues especially as you grow older. And this is another important slide, the cost effectiveness of LAC. So if you see the red line represents actually warfarin, the blue line represents left atrial appendage, the green line represents NOAC. And if you take into time to cost effectiveness and actually put into perspective the bleeding complications, the rate of strokes, all the hospitalization, by 5 years, you're more cost effective and clinically effective than NOACs. And so I think this is an important set of data, because if you start taking NOACs, remember you're putting yourself to risk of bleeding also.
You don't have 20-year data on LAA, so that line is actuarial.
Well, it's actuarial, right. That's why you have data up till 5 years.
No, I understand, but I mean, to be honest, like, how long do those patients live for? I mean, that's very optimistic, that line, is it not? I mean,
No, it's not optimistic, because remember, even when we had 5 years of data in PREVAIL, remember the many patients went up till 7 years, right? 5 years means everyone was followed up till 5 years. And by the way, you don't have any NOAC data for 5 years, sir. You have 18,000 patients, and everyone was a 1-year publication.
the whole curve is made up then, right? The
That's,
NOAC part and
that's right.
that's what I just wanted to understand.
Extrapolate.
Yeah, yeah.
Extrapolate versus made up is,
Well, it's a Kaplan-Meier curve, because some of the patients got 5 years, 4 years, and 3 years, right?
Frame it. You got to frame it properly. Yeah. It's all about framing.
So this is our conclusion. It's safe. It reduces the risk of stroke equivalent to Coumadin. There's a long-term mortality benefit. It reduces major bleeding. It reduces the risk of disabling strokes, and it's probably cost-effective on the long term. So these are the summary of what we think it is at the present moment. It is not yet approved for patients who cannot take any anticoagulants. That is important. That's why the FDA wants us to do a study called ASAP-2, where we are randomizing patients who cannot take anything to just baby aspirin or nothing versus a Watchman,
but I thought the coverage decision was for people who were,
who can take, the wordings are, who have reasons for not taking long-term anticoagulation, but can at least take short-term. And the reason for that, Eric, is because in the clinical trial, it was required that they had 45 days of it, right? Right, John? And that is the reason why I think the wordings of Medicare is correct. So the concerns, is it not perfect? There's a small incidence of device-related thrombus. We just published a paper in Circulation last week, which has brought a concern about 3 to 4% have device-related thrombus. It requires a need for short-term anticoagulation. So if people cannot take anything who need it the most, it may not be safe. The safety is unknown in patients who cannot take anything. And finally, not proven to be effect in valvular atrial fibrillation. So these are some of the caveats in all the patients. Who should be getting it? Simple. You look at the CHAS-VAS score. That's a risk of scoring. The higher your CHAS-VAS score, your risk of stroke is higher. So if you have a CHAS-VAS score 1, you probably don't need anything. You take into consideration the Hasbled score. This is a risk which assesses your bleeding risk. Of course, I tell people don't use any of these scores. Use a score called common sense, and I think that's more relevant. But the way to look at it is this diagram. So if you take a patient who's a low bleeding risk and a low stroke risk, you probably can just give him aspirin. On the other hand, if the patient has a low stroke risk and a high bleeding risk, you'll give them nothing. But if a patient has a high rate of stroke, high risk of stroke, that means a CHAS-VAS of 2, and a low bleeding risk, he's a perfect candidate for NOACs or warfarin. And the patient has a high bleeding score rate and a high bleeding risk score, give him a left atrial appendage closure. So that I think that's probably the population which will benefit the most, right? This is the FDA usage guidelines, which you asked me. Patient had a risk of stroke based on their CHAS-VAS score, are suitable to take warfarin, but have reasons or rationale for not taking long-term anticoagulation. So it's kind of silly. Like say if a patient says, I want to ski, I'm going to fall, that's reasonable. You can say non-compliant. These are the patients you should say no to, because these are the ones. Valvular atrial fibrillation, as I said, low risk of stroke. If his stroke rate is very, say a young patient with no other problems, limited life expectancy. If the life expectancy is less than 1 year, you shouldn't be doing it. Very low ejection fraction patients. These were excluded from the study, and I've actually had a patient with a EF of 20%, which I did an LA appendage closure, and 45 days later he had a huge thrombus on the device. So you have to be very careful of these. Patients who cannot take any form of antithrombotic therapy, if your anatomy is not suitable, either too small or too large, or you have thrombus, okay? And then your conclusions are, therefore, this is the conclusion. Who's the ideal patient with non-valvular AFib? You should consider closure. Just be a good clinician. And it should be ideal for patients who cannot, who should not, and who will not take long-term anticoagulants. Thank you.
That was great, Saibal. Thank you so much. Are there any questions? I have one question. So let me ask you about the patient with paroxysmal atrial fibrillation. So you get referred a patient who's had one episode of atrial fibrillation on a Holter monitor that lasted 10 seconds. He's got a CHA2DS2-VASc score of 2, or you know, he's at stroke risk, and he can't take anticoagulation. You've been referred by your colleague to put in LAA occluder. He's in sinus rhythm 99% of the time, as far as you know, on a 14-day Holter.
That's not even a paroxysmal atrial fibrillation.
Well,
it's considered to be a single episode of AFib.
Well, say it's a little, like, I mean, say there's 2, 3, or 3 brief episodes on a 14-day. So would you put that patient
And what's his
on-
CHA2DS2-VASc score?
His CHA2DS2-VASc score is 2 or greater.
2.
Yeah.
Would you consider that patient for a long-term anticoagulant?
So if he is at, so that's the first question, right? So he can't take anticoagulation.
Oh, he cannot.
No, he cannot.
But
He's been
let's say-
referred 'cause
oh,
he's
put it
had
this way.
multiple bleedings.
Let's say
He's had multiple
he-
bleeding episodes.
All right. Let's say he didn't have a
So
problem
he's
with
already
bleeding.
been on anticoagulation.
So he was, okay.
Yes.
So once the patient was destined to be on anticoagulants based on your clinical judgment, that means this becomes a treatment strategy. If
But
you
which-
had thought, if you thought that, look, he's not going to be on blood thinners, it's not indicated, then you shouldn't do the procedure. But if you in your mind thought this patient, based on his CHA2DS2-VASc score, is indicated for long-term blood thinners, then it means you're submitting yourself to the fact that he's at risk of stroke, that means you should do the procedure.
So, go ahead.
So sorry, I just.
In fact, I personally feel patients with paroxysmal AFib benefit the most. I'll tell you why. I tell patients, let's say he has 4 episodes of AFib, correct, in 1 year. So I say, look, you're submitting yourself to a daily risk of bleeding, taking 365 days a medication for preventing a stroke for 5 days. Why would you do that to yourself when you can actually have a permanent solution and just close it off?
So I guess,
You take people who are eligible for anticoagulation.
Absolutely.
Because of preference?
Absolutely.
Absolutely. Okay.
That's why I say as an alternative. That's the ideal patient. John, do you agree with that argument? What I'm saying that I think the risk benefit is even worse for paroxysmal AFib. Young patients, we don't have a study. What if a patient comes 65 years old, who is 60 years, where his life expectancy is another 20, 30 years? Would you subject a guy for 20, 30 years on blood thinner?
well, I don't know. I mean, I think the issue, like you said, is that, you know, patients don't want to be on a blood thinner medicine, and so they've been referred because their cardiologist suggested that they do, because they've had a couple episodes of paroxysmal atrial fibrillation, and they don't want it, so they suggest, well, why don't you put in an occluder device?
So one of the things which I think is very good, Medicare requires that the patient be seen or referred by a non-implanting physician. So if the non-implanting physician feels that the patient would have benefited from long-term anticoagulation, then that patient is indicated. If the non-implanting physician
The
feels,
doctor is usually not the expert, right?
Yeah,
They're asking for
they-
an opinion from
yeah.
an expert.
no, he can make a decision of whether the patient would be a candidate for blood thinners, right? He's at risk of stroke. If he says, look, Saibal, this guy's risk of stroke is less than 1% per year, I said, don't do anything.
John, are you taking people off anticoagulation because they're based on preference, or no? You do that?
I don't think preference would, at our place, be enough. They have to have a compelling reason for wanting to avoid long-term anticoagulation, which can be episodes of overt bleeding or high risk of falls, et cetera. I think that's a
So
little
John,
more
I
compelling, but-
usually refer people who are not going to take it as non-compliance. See, one of the factors in medicine is non-compliance, right?
I find this just a very challenging field for decision-making. And there's certainly a spectrum of use of left atrial appendage occlusion that shows how, number one, I do think we need more randomized data, and hopefully the
Yes.
ambulance trial will, and the other ongoing trials will provide us with that. And,
So that's the problem though, John.
Yeah.
The ambulance study is a device versus device trial.
yeah,
So it's not really, what we do need is more studies of device versus medical therapy, correct? Versus NOACs.
The data is like, to me, the data smelled too hocus pocus.
Oh.
Too hocus pocus, retrospective controls, not enough people, small study.
No, there was no retrospective controls in the PROTECT AF Prevail. They were contemporary controls. That analysis that I should have,
I think they.
yeah, they were randomized, absolutely. They're see, the reason why the FDA had this concern was the PROTECT AF showed a clear survival and mortality benefit with stroke. The Prevail trial, the second study, which was smaller, showed ischemic strokes to be slightly higher. That was the problem. The first study was 900 patients, 2-to-1 randomization. The second study was only 400 patients. And that was,
9,000 patients in a NOAC trial to have adequate power to say that.
that's an issue. So it's not easy to have device-related study. Like, for example, do you do primary PCI or thrombolysis for acute MI? Okay. Do you know how many randomized trials there are with that?
It took a
Okay,
while.
there's the answer.
Yeah. It's wonderful having this option for many patients. Number two, I think the safety of the procedure has significantly improved. And that's key. And third, some of it is also you have to have expectation. This is a targeted therapy for the prevention of one stroke mechanism. And just look
Yes.
at what these risk scores involve. These people are loaded with vascular risk.
That's
stroke.
right.
Yeah.
Yes.
And they have other kinds of risks.
Right.
other
And we
kinds
have
of
to make that
stroke. So-
clear. You're right.
Yeah.
John's point is when you
So-
do a CHADS-VAS score, it includes hypertension, diabetes, coronary artery disease.
Yeah.
These people are at risk of stroke for other causes of stroke. So all we're doing is reducing the risk of stroke from just one mechanism.
So Saibol, at last year's Horst Sievert's course, he was doing a live case, an appendage closure, and he said to the audience, I don't know how the question came up, he considers left atrial appendage occlusion one of the most challenging interventions he performs. And I kind of sat back, this is Horst saying that.
Yeah.
What makes someone like Horst say that? Is it the diversity of the anatomy
Yeah.
and fitting the device is
It's
challenging?
everybody's LA appendage looks different. In fact, I think the new way of identifying people is not by fingerprints, it's probably by LA appendages. Everyone's going to have his LA appendage drawn out. It's different, and that's one of the problems. It is true. The other thing, Horst's comment is correct, that in TAVI or in MitraClip, if the patient dies after a procedure, it's probably acceptable because the patient would have died anyway. But if you do an LA appendage closure, you have a death. That's a huge
That's
problem.
a big deal.
Because that
And-
patient wouldn't have
But
died.
that's also
Not
because,
want to run to the OR, like, those
No.
patients are not typically patients who have amyloid angiopathy, patients who have recurrent, like, cerebral bleeding. Like,
Right.
Those patients are not going to the OR if they
Right.
have a problem, you know?
Yeah.
But-
So that's
but-
why you have to be squeaky safe.
Yeah.
If your complication rate exceeds 2%,
Yeah, we've got problems.
then
Yeah.
you shouldn't do it, or you shouldn't be doing it.
but really that speaks to the data, right? I mean, if the data was stronger, then it would be less of an issue. If I mean, if
No, the Mark, the data was very strong for safety.
right, but I'm
in
just
all
saying
the
that speaks
clinical-
to the data about TAVI because you're saying, well, TAVI it's okay because the data is so strong to do something, right? And if something but the data in LAA has always been
The
a
data
little
for LA
murky.
was safety was no question. In fact, I remember during the vote, it was 13-0 in favor of safety. When it came to efficacy, it was like a neutral vote, right? And when it came to risk-benefit ratio, it went in favor of us. But the reason why it was, to me, was most impressive was it was 13-0 in safety. Whereas in 2009, it was 7-5.
Yeah.
5 voted against. And what we did show, as John said, over time, we demonstrated the procedure can be made safe. And the procedure has become more safe. If it wasn't so safe, we probably wouldn't have done it, or shouldn't be doing it.
Great job,
Thanks,
Saibol.
Saibal.
Thank you.